In this video, I'm going to discuss the MSK sensory exam. I'm going to focus on light touch, but you can utilize the Asia exam cartoon to identify where to perform the pinprick exam for each level if you want to assess for pain. When assessing for light touch, you are looking for asymmetry, typically for diminished sensation versus hyperesthesia or heightened sensation. You may also find a patient who has allodynia, pain out of proportion to the applied stimulus. Typically, this may feel like burning or stabbing pain. These findings can clue you into a neurologic source of their symptoms, and with an understanding of dermatomes and peripheral nerve distributions, the findings can help you localize the lesion. To remember dermatomal distributions, it's best to start with an easy-to-remember dermatome as an anchor. In the upper extremity, I use a mnemonic 6-shooter to remember that the C6 dermatome includes the thumb and index finger. From there, I know that C5 is proximal lateral humerus, and C7 is the middle finger. I then continue to work my way down to C8, the ring and pinky, T1, the medial forearm, and T2, the proximal medial arm, into the chest. If someone has decreased sensation over their index finger and thumb, the top of my differential includes a C6 radiculopathy versus a median nerve injury, most commonly carpal tunnel. With a solid understanding of dermatomes and peripheral nerve sensory distributions, the sensory exam can help you rapidly narrow your differential diagnosis. To remember thoracic dermatomes, I remember the dermatomes with an easy landmark. T4 is the nipple and T10 is the belly button. But 10. Between T4 and T10, you can approximate which dermatome a patient has symptoms. This is particularly important when a patient presents with shingles and you need to document the level of the lesions. To remember the lower extremity, I remember L3 is the knee, L2 is the thigh above, and L1 is the groin. Distally, L4 is the medial leg, and L5 is a lateral leg into the dorsum of the foot. S1 is the plantar aspect of the foot and posterior leg, and S2 is the posterior thigh. If a patient presents with numbness isolated to their lateral leg and dorsum of their foot, my top differential includes an L5 radiculopathy and perineal nerve lesion. Once again, the sensory exam can help me to narrow the differential with an understanding of dermatomes and peripheral nerve sensory distributions. For the dermatomal exam, it's nice to have the patient in anatomical position with their palms on the ventral aspect of their body. You start up proximally into the C5 region. Then you go to the C6 region into their fingers, the C7, the C8, and then the T1 in the medial aspect of their arm. It's also important to check the dorsum. If there's a radial nerve lesion, you might just find isolated lack of sensation in the dorsum of their hand. It's also important to remember that loss of sensation in the fourth and fifth finger could be related to an ulnar nerve injury, or in the first to third fingers could be related to a median nerve injury. The sensory exam, you're going to want to compare each side with light touch. You will ask the patient if they can feel it, and if it's the same or different on each side. You're looking for either diminished sensation or increased sensation. At times, patients may experience hyperesthesia or allodynia to light touch, uncharacterized pain or sensation to the amount of force in your touch. We start with L2. This is the proximal thigh. L3 is the knee, a great place to remember as a reference point. L4 is the medial calf. L5 is the lateral leg, lateral calf into the dorsum of the foot. And S1 is the plantar aspect of the foot.